Hi, I'm Gillian Howard, a CCP intern. This is a short video on the pelvic binder, which will hopefully help with the application of the Prometheus pelvic binder, something that we as paramedics often have difficulties applying correctly. Before we look at the application of the pelvic binder, it is important to understand when pelvic fractures can occur. In both the adult and pediatric populations, significant forces are often required to cause a pelvic fracture, while in the geriatric population, low energy and mechanism traumas can cause pelvic fractures. When looking at pelvic fractures, the Young Burgess classification is often used to define the four categories of pelvic fractures. These categories include lateral compression fractures, which occur where the side of the pelvis receives a blow or compression, causing the pelvis to rotate inwards. This type of fracture is often seen in RTCs or falls from height with a side impact or where a person has been run over. Another category is the anterior-posterior compression fractures, which is caused by frontal impact to the pelvis that causes the innominate bones and the symphysis pubis to spring open. In this type of fracture, where significant disruption to the pelvis occurs, it is often referred to as an open book pelvis fracture. Common causes of this type of fracture occur from head-on collisions, motorcycle accidents, and equestrian accidents. The third category of pelvic fractures is the vertical shear fractures. This occurs where one side of the pelvic ring is sheared or vertically displaced from the other side. In this type of fracture, neurological injuries are more likely to occur. The most common cause of this type of fracture are falls from height where axial loading injuries occur, or where motorcycle accidents occur with one leg of the patient being more forcefully loaded than the other. The final category of pelvic fractures is combined mechanism fractures, which are a combination of the aforementioned fractures. This often occurs due to high mechanism incidence. While pediatric patients are less likely to suffer from a pelvic fracture than an adult, it is important that we do not discount them from pelvic fractures due to their young age. Pediatric patients are most likely to suffer a pelvic fracture due to high mechanism incidents, such as being struck by a car or being involved in an RTC. Pediatric patients will also suffer less serious pelvic fractures, such as avulsion fractures, through sporting injuries. There are a number of risk factors that increase the risk of a patient suffering from a pelvic fracture. These include age. Patients over the age of 60 years are more likely to suffer from a pelvic fracture. They're also more likely to suffer from significant bleeding as a result of the pelvic fracture. Patients of low density or patients that smoke are also at risk of pelvic fractures. Another risk factor are patients with a propensity to fall. And finally, patients that have previously undergone hysterectomies are also at risk of pelvic fractures. So we've looked at some common causes for pelvic fractures, as well as those patients that are at increased risk of suffering from pelvic fractures. So why is identification of patients at risk of pelvic fractures important? And why is it important that we appropriately manage this patient in this setting? The answer is simple. The mortality in pelvic fractures is between 8 and 40%, with patients suffering from open book pelvic fractures at a 3 times higher mortality rate than those suffering from non-open book fractures. The mortality rate in open book fractures can also be as high as 50% mortality. Mortality is also increased in patients with a systolic blood pressure less than 90, patients aged greater than 60 years, as well as patients suffering from associated injuries. Early mortality in these patients occurs due to inappropriate control of bleeding. This can be as simple as delayed application of a pelvic binder. This therefore highlights the need to apply a pelvic binder within an appropriate time frame, and also why it is so important to actually apply the binder. We know that pelvic fractures have significant consequences on patient mortality. So how does a pelvic binder, when applied correctly, affect this? Well, in open book fractures, it has been found to reduce the pelvic volume and assist tamponading bleeding bones and vessels in the pelvis, both of which are beneficial in the management of the patient's hemodynamics. It has also been found to prevent further injury to the pelvic area from the movement of pelvic fractures, which can occur through simple things such as transporting the patient to hospital. It can also provide a level of pain managed to the patient, much like a vacuum splint can provide to a fractured limb. With non-open book fractures, binding will not reduce the fracture of the pelvic volume. However, it will stabilize the pelvis, which in turn prevents further injury and reduces the patient's pain. Pelvic binders should not, however, be applied to lateral compression fractures, particularly where there is internal rotation, as it can exacerbate the injury. That being said, and unfortunately in the pre-hospital environment, it is almost impossible to diagnose this type of fracture. If you're still unsure about the application of the pelvic binder, despite everything discussed thus far, some clinical pearls that I have found that may assist in decision making include: the extent of the internal bleeding may not correlate with the severity of the pelvic fracture, meaning just because a patient presents as hemodynamically stable does not necessarily mean they do not have a significant pelvic injury. The other clinical pearl is that older patients may have significant pelvic fractures and/or hemorrhaging from low energy falls. It is a warning: be wary of the elderly falls patient. Now that we've refreshed our knowledge on pelvic fractures and common causes for them, it's time to look at when the pelvic binder application is indicated. Looking at the QAS CPM, it states that where there is a mechanism of injury that is suggestive of a pelvic fracture or fractures, then a Prometheus pelvic binder should be applied where there is hemodynamic instability, where the patient is less than a GCS of 13, the patient has any distracting injuries, or on your clinical assessment, there is abnormalities of high likelihood of a fracture. While this is a broad statement, things that may assist in your clinical assessment include whether the patient was ambulatory at the accident scene, the localization of the patient's pain, the presence of any bowel or bladder incontinence, the presence of any numbness or weakness for the patient, and bleeding, whether it be hematuria, rectal, or vaginal bleeding. Turning to contraindications for the application of the pelvic binder, the QAS CPM contraindicates the application of the pelvic binder in patients who have suspected isolated neck or femur fracture or suspected isolated hip dislocation. Like anything we do, complications can arise from the procedure that we undertake. We should be wary of complications that arise from the pelvic binder, which include pressure areas and tissue necrosis. These complications can often be overcome by the correct placement of the pelvic binder, and more specifically, ensuring all of the patient's clothes are removed in the locality of the pelvic binder placement. So moving on to the actual application of the pelvic binder. Before we can apply it, we first have to identify the correct anatomical landmark, being the graded canter. As paramedics, we often have difficulties correctly identifying this. This is often because we try to palpate the graded canter, which can be difficult to palpate in our patients, either due to patient's body habitus or uncertainties in identifying the correct anatomical structures of the patient. Other methods that I have found useful in identifying the patient's graded canter include palpating down the patient's pelvic region and to locate the patient's pubic symphysis, which aligns with the graded canter. The other method that I use, and which is particularly useful if you're not comfortable in palpating the pelvic region of the patient given the proximity to the patient's genitalia, is laying the patient's arms straightened by their sides. In this position, the alignment of the patient's wrists against the leg will indicate the patient's graded canter. This can be seen on the picture on your screen. I will run through these three different methods shortly when I demonstrate the application of the pelvic binder.
To place the pelvic binder, the first step is to lay the patient supine, straightening out the patient's legs. We then need to remove any clothing that the patient is wearing. The next step is to identify our anatomical landmarks, which in this case is the graded canters. To do this, we can either palpate down the patient's body to find those, or alternatively, we can feel for the patient's pubic symphysis, which will line up with the patient's graded canters. If you're uncomfortable in doing this, another way is to lay the patient's arms beside their side and the crease of their wrist lines up with the patient's graded canters. The next step is to grab our pelvic binder, where we're going to place the pelvic binder, which is folded in half beside the patient's body, with the centre of the pelvic binder aligning with the graded canters. We'll then fold down the top half, laying beside the patient's leg, as Jeff has just demonstrated. The next step is to get the pelvic binder underneath the patient. With minimal movement of the patient, we're going to roll the patient as Jeff slides the binder underneath the patient. Once Jeff's in the position, he's going to roll the patient back towards him. And I'm going to unfold the binder that is placed underneath him. We're then going to check the positioning of the binder, ensuring that the graded canters are in the centre of the binder. Jeff, if you could grab the security straps for me. We're now going to put the blue triangles across the top of the graded canters. Once in place and we're happy with positioning, we're then going to cut the pelvic binder to fit. So you'll notice Jeff cutting the pelvic binder just above the blue securing triangles. And he's going to do it on this side for me as well. This now leaves the inguinal region exposed. We're then going to grab the securing straps, making sure that the buckle is in the centre. And with equal force, we're going to apply tension to the patient's pelvis. Once adequate tension is applied, we're going to secure the blue straps to the pelvic binder. We now have our pelvic binder in place and securing and stabilising the patient's pelvis.
As you saw, the application of the pelvic binder is relatively straightforward. However, there are a number of common errors that are seen when it comes to pelvic injuries and the pelvic binder. The main errors include not applying a pelvic binder when indicated to do so, incorrect placement of the pelvic binder, meaning that it is placed either too high or too low on the patient, paramedics not removing the clothing of the patient prior to applying the pelvic binder, not cutting the Prometheus pelvic binder to the appropriate length, and either not applying adequate tension or applying uneven tension to the binder. While a common error is not to apply enough tension to the binder, care should also be given not to apply too much tension. This is particularly relevant in lateral compression injuries, where excessive tension can cause excessive reduction in the pelvis and can create or increase an internal rotation deformity of the pelvis and thereby lead to increased hemorrhaging and injury for the patient. While I've just talked about some common errors that we see in the application of pelvic binders, I thought it important to share some tricks that I have learned in applying pelvic binders. These tricks help me in applying the pelvic binder to the correct anatomical location on the patient. The first trick is, if I'm placing a patient on a combi carrier, then I place the folded pelvic binder on the combi carrier so that I can place both the combi carrier and the pelvic binder under the patient in one procedure. This assists me in correctly placing the pelvic binder in the right anatomical position for the patient, as well as reducing the movement of the patient and the need to roll the patient multiple times, namely rolling the patient to place the combi carrier under the patient, as well as rolling the patient a second time to place the pelvic binder. The second tip that I have is in cases where I cannot apply the pelvic binder prior to extrication, then I place the pelvic binder onto the stretcher in the approximate position that I think it will be required for the patient. Again, this assists me in correctly putting the pelvic binder in the right anatomical location for the patient. It also again assists me in reducing movement of the patient by having to again roll the patient just to place the pelvic binder. In instances where the patient is indicated for both a Schlichmann femoral splint and a pelvic binder, then it should be remembered that both can be applied to the patient. Just remember, however, that the pelvic binder must be applied first, followed by the Schlichmann femoral splint. Hopefully this video has assisted to refresh your knowledge on pelvic fractures and common causes of pelvic fractures, as well as assist you in future application of pelvic binders to your patients. To test your knowledge on what you have watched today, and which can be used for your annual CPD, please pause this video and using the camera application on your phone, access this short quiz via the QR code. The information collated from this quiz may also assist in guiding future training. If you wish to look at pelvic fractures and pelvic binders further, here are some useful sources that I've utilised in the creation of this video. Thanks for taking the time to listen to this video, and hopefully you've got some helpful information from it.